This podcast has been sponsored by Ardelyx. Maintaining a healthy gut is key for overall physical and mental well-being. Whether you're a health-conscious advocate, an individual navigating the complexities of living with GI issues, or a healthcare provider, you are in the right place. The Gut Health Podcast will empower you with a fascinating scientific connection between your brain, food, and the gut. Come join us. We welcome you. Hello, friends, and welcome to the Gut Health Podcast, where we talk about all things related to your gut and well-being. We are your hosts. I'm Kate Scarlatta, a GI dietitian.
And I'm Dr. Megan Reel, a GI health psychologist.
So we have a new format that we're sharing with you today, and this is a podcast series. It's a mini-series with 3 episodes. We're going to take a deeper dive into the diagnosis and treatment of constipation predominant irritable bowel syndrome.
That's right. Kate and I really put some thought and effort into bringing you experts, including our expert today. We're going to dive into the subject matter of our book, Mind Your Gut. And in this first part of this IBS series, we're going to talk about the pathways to relief. So really understanding medications for the symptom of constipation. We will be exploring the options from pharmaceuticological to over-the-counter medications and how they work.
Awesome. So let's get to it. Let's introduce our incredible expert guest. He's a good friend and just an amazing clinician that we really appreciate his approach to care in IBS. So Dr. Justin Brandler is a motility expert from Virginia Mason Franciscan Health in Seattle, Washington. Dr. Brandler cares for his patients with GI conditions, both complex and general, through evidence-based medicine and comprehensive personalized care plans developed through a strong patient-physician partnership. He desires to empower patients with tools for hope and healing. In addition to using medications to treat disease, Dr. Brandler thoughtfully harnesses therapeutic tools from nutrition, yay, psychology, double yay, integrative medicine, and spiritual care. He strives to earn his patients' trust, and we know the trust relationship is so huge, especially in IBS, and seeks to provide a safe and welcoming space through empathetic listening, humor, and compassionate care.
Welcome, Dr. Brandler.
Thanks, you guys, so much for having me. It's like bucket list, be on Gut Health Podcast, check. So what an accomplishment. So thank you so much for having me.
We're happy to have you.
Yes, we were both thrilled as we were thinking about, who do we want to speak on this topic? And while the point of today is to talk about some of the pathways to recovery here and to care, you really approach this, you walk this with your patients. And while medication can be such an important part of the treatment plan, you certainly bring the holistic to multidisciplinary care that we can appreciate from the physician lens.
And I'll say that Megan mentioned your name, and I was like, yes, yes, and yes, he is perfect for this episode. I was so psyched. So we're thrilled to have you here beyond. Yeah, really happy.
So we're going to dive in. We're going to start with an easy one, a nice little softball for a complex disorder. So I especially love probably the way you describe this to people to humanize this diagnosis. So tell us what IBS is, how common is it, and how do we treat it?
Yeah, so IBS is incredibly common, albeit complex. And I think that's the uniqueness of it, is that every patient that comes to me, so I am a neurogastroenterologist, motility specialist, brain-gut connection doctor, of which IBS, or irritable bowel syndrome, is under the umbrella of these DGBIs, or disorders of gut-brain interaction. So that's kind of a large umbrella term. But underneath that is irritable bowel syndrome, of which there can be a lot of different, what we say, pathophysiological, or basically how your body works and how it's not working well, processes that can contribute to this. As far as prevalence, actually, there was a global prevalence study published in 2020 by the Rome Foundation that showed that up to 40% of the US population has a functional GI disease or a DGBI in general, of which there have been different estimates, but around 6 to 8% of the US population has irritable bowel syndrome, which is a huge number when you think about that. I mean, that's almost 10%, so like 1 out of 10. And if you see people lined up at the, supermarket waiting for their self-checkout and there's 10 people, one of them probably has IBS and one of them may be you. So, it's incredibly common, but incredibly complex, and I think needs to be respected as such when we're approaching these patients.
That study you were mentioning, I love that study. And I use that a lot to highlight and normalize. And I think even taking that 40% a little further, that group was at a risk of about 30%. So all of the people that have one DGBI, 30% have two DGBIs. So it really then encompasses upper and lower. And just as a kind of FYI for our listeners, the beauty of many of the things that we're going to talk about over the course of this series, medications included, but lifestyle and nutrition, is that many of these interventions have been studied for lower GI, but they can apply to upper GI conditions as well. So I'll use hypnosis as one example. It's just that how we use hypnosis for lower DGBIs, irritable bowel syndrome, it can be very effective for upper GI. So not to dive into that too far today, but just again to highlight people are suffering from mouth to anus.
They are. And I would say, same with diet. There's applications that we use for IBS that may help with functional dyspepsia.
That's right.
That overlap is significant.
So what's your elevator pitch, real quick, for patients that have been newly diagnosed with IBS? What do you tell them off the bat?
Yeah, I definitely have so many elevator pitches, as you guys know. That's kind of my shtick. And I actually teach a class called Brain Gut Coaching Class via Zoom that's billable to their insurance because it is so hard to really do a deeper dive with these patients in clinic. We just don't have time, and so we kind of outsource it that way. But from a high level view, what I say is, as a brain gut specialist, I'm basically a glorified plumber and electrician. So I think about it from a plumbing standpoint, being a gastroenterologist, so the mouth to anus, like how the bowels, the stomach, the small bowel, large bowel, those types of things. And sometimes we target treatments based off plumbing alone, depending upon the situation. But there also can be a connection with the electricity. So that's where the neuro fits in, or the neurological nervous system, and what a deep connection there is between our brain and our gut, both within the brain's nervous system, both within the gut's nervous system, called the enteric nervous system, which is kind of felt to be maybe a second brain. And then there's also the connection in between, which is often the vagus nerve, if you've heard of the vagus nerve, as well as some other nerve pathways. So that's kind of a high level view of the physiology. But from an emotional standpoint, I guess even before that, I just sit and look at them and I tell them, I believe you. I mean, honestly, that's the first step, or at least I present that non-verbally, because these conditions are so challenging, because a lot of the testing that we have currently, or biomarkers, what we say, can't really capture it. A lot of times it's the patient where their lab studies are normal, their CT scan is normal, they're shuttled out the door saying there's nothing wrong with you, and the patient is left feeling like nobody believes me. They think it's all in my head. Whereas I say an elevator speech would be, it's not all in your head, but part of it is in your brain and spinal cord, within your nervous system. Because I think if we do totally take away the head piece, we take off the table so many helpful tools that people like Dr. Megan Reel and others can use in the psychological realm, as well as medications, which we'll talk about.
Well, I got the chills. First of all, I started a campaign, I believe in your story. And so it is so vital and provides just such trust in that relationship when you feel like you're believed. I mean, that should be normal, right? And with a lack of biomarkers and not having something objective to sink your teeth in, it does leave patients feeling a little bit like, what the heck do I have? And do I really have this? So I'm really glad you said that. Lots of little chills in your little elevator speech for Kate Scarlatta. So let's get into medical treatments a little bit, because we know that, at least, I've been doing this for 30 years, and the majority of people that I work with, they don't just require diet alone. Some do. Some benefit from gut-directed hypnosis, and that's all they need. But I feel like the majority need like a full toolbox. And medications can really, I think they're stigmatized a little bit, like it's a cop-out. But these medications can really be life-changing and really address the plumbing issue in many cases in constipation. So can you just go into a deep dive between pharmaceutical medications as well as some of the over-the-counter medications that people might grab to alleviate some of the constipation and symptoms associated with that?
Totally. So diving into a few more metaphors I use here a bit. So as far as the toolkit, I love the toolkit concept. I actually use that because it's a lot of specialists. I say I specialize in making a lot of friends and maintaining them because I need their help. So I think of it as the team concept, and at Virginia Mason, we're team medicine. So, sometimes there are team members that will be on the field. So those will be tools that we will use. We'll refer to GI dietitians, we'll refer to GI psychologists. But maybe that's for a time, and maybe they'll go off the field for a while, and we bring in the pelvic floor physical therapist, for example, take them off the bench for a season, because you're a human being who has a life. You can't be going to visits all the time. So I think the overarching team metaphor is really helpful when approaching the toolkit. And then when we dive into the toolkit for constipation in particular, I'm actually going to steal a metaphor from both Dr. Reel and my mentor, Bill Che, who taught me about the toothpaste metaphor for constipation. So I use this all the time, especially before I'm doing a rectal exam. So when you think about it, think about a toothpaste tube with a cap on the bottom. The cap is the anus, and you want it to loosen well enough to let the poop out. You want it to tighten well enough to keep the poop in. So when we focus on the cap level of management, that can be a pelvic floor physical therapist, not even necessarily medication management. And a lot of times these patients are like, I just want to get better and be done, and no meds and no whatever. And I'm like, okay, well, we do have to, there's no magic wand. That's not a good pitch, because that's not true. But if anybody was a magic wand, it would be a pelvic floor physical therapist, because they can really help guide you through a lot of helpful non-medicine tools. But if we go upstream in the toothpaste tube metaphor, we can think of it both from the paste standpoint as well as from the tube standpoint. So from a paste standpoint, soluble fiber can be very helpful. However, it's a double-edged sword. So we want to start low and go slow if we're doing fiber management. The most evidence-based would be psyllium fiber or Metamucil, which is the bright orange container in the stores. And you can go week by week, increase teaspoon by teaspoon to get to that soft banana stool. Alternatively, albeit less evidence-based but helpful for the bloaters, is Citrasil. So it's metabolized a little bit differently, but a little less bloaty. So that can be a dietary management. And also you reach out to your friendly GI dietitian, bring them on the field for your dietary fiber options, especially maybe lower bloaty fiber options such as 2 green kiwis, which has been studied in randomized controlled trials to be beneficial. So that's part of the paste management. Now, going up a little level to more medication management, and we'll start with over-the-counters. So one medication that can be really helpful and people feel more as kind of a natural option is magnesium oxide, or really any magnesium product. I use this all the time now, and there was actually a recent randomized controlled trial comparing it to Senna, and it was equivalent. We'll talk about Senna in a second. But magnesium oxide can be helpful for a few reasons. It's called an osmotic laxative, so it can help to kind of soften that paste a little bit. Also, to a certain degree, the magnesium can have a muscle relaxant effect, as well as a lot of my patients have benefit with sleep if they take it at night. So it can kind of serve a lot of different modalities. You want to get it from a reputable company that's been third-party tested so it has the right amount of magnesium, and you want to avoid it if you have chronic kidney disease. But for the vast majority of people, it's incredibly safe and effective.
Can I just interject? Like, where do you start with magnesium? Do you start at a certain dose?
So what I tell them is magnesium oxide 400 milligrams, because that's how it's been most studied. And I started at one a day. And oftentimes I advise them at night because of that sleep benefit. And then we can increase each week. We say at night and then maybe in the morning. And then it's even been studied up to 3 times a day. 1200 milligrams is perfectly safe for people. Now, there are so many magnesium products, and it is insanely confusing. I kind of try to center them on oxide because it's a little bit more of a nice balance between absorption by the GI tract and getting those blood levels higher, which can help the sleep medicine, but it also stays within the bowel to help that stool softening effect, as opposed to like magnesium citrate, which theoretically maybe stays more in the bowel and has a bit more cramping effect for some people, not always, but some. And then on the other end is like magnesium glycinate, for example. That's absorbed more by the GI tract and has a bit more evidence for like headaches and sleep and stuff like that, but may not have as much constipation benefit. But it really, unfortunately, is a bit of trial and error. And I have patients along the spectrum, and we just kind of go with what works. So as far as other paste options, Miralax, is a tried and true. That's usually in a white container with a purple cap at the store, over the counter, generally relatively safe. There is some evidence that's starting to develop in terms of long-term side effects when you've been on it for a long time, potentially from a neuropsychiatric standpoint. That evidence still has to evolve more. And especially in my little old lady who's like 70 or 80, that I'm like, that is a long-term consequence. I don't care about that for you. I just want you to be feeling better.
Right.
And the other trick here is it's recommended as a full capful. Sometimes that's too much and that gets you too liquidy. You can always break the rules a little bit and go to a half capful. It's not against the law. Nobody's going to come and get you. And that can actually be all it's needed. And then there are a few other ones, Docusate, which is like a stool softener, actually pretty minimal evidence there. One of my friends when I was at Mayo, Ali Yang, who's now in the Harvard system, I believe, she described it as all mush, no push. So it really just softens the stool, which can be really helpful for somebody who doesn't have motility issues, but it's more of they have an anal fissure, for example, and they just really want to get something smooth by that anal fissure. That can be a helpful tool. So, that's kind of a bird's eye view, I think, of the paste type of interventions where we can help soften the stool. That's more in the osmotic laxative category. I guess another one, if we're going to go in prescriptions and we're going to stay in the paste world, now we're going to enter into the prescription medicines. So that's something like linaclotide, for example, or Linzess. Another one is lubiprostone or Amitiza. I actually don't like that one as much because it has a high risk of nausea, although insurance loves to force you to go through that because it's cheaper. And then another one is plecanatide or Trulance. Basically, all three of those work in a very similar mechanism. Lubiprostone's a little different, but essentially it helps to secrete fluid from the small bowel into the large bowel and out. And especially linaclotide and plecanatide, and I guess lubiprostone to a certain extent, are indicated for both chronic idiopathic constipation, so that's constipation without the pain, as well as IBS with constipation, which is constipation with the pain. And how we think that works maybe is through affecting the pain receptors and helping those numb those down a bit. So those are some prescription options in that realm. Another new kid on the block, which is pretty exciting, is tenapanor or Ibsrela. So that one is indicated for IBS with constipation predominance, and it actually is a totally new mechanism of action that we kind of think as almost a retainagogue. So as opposed to the secretagogues, where they secrete fluid, this one actually blocks a certain receptor to keep fluid or retain the fluid within the small bowel so that it comes out. And in some ways, maybe a little less diarrhea side effect with this guy, as well as if you hang on to it for 6 to 8 weeks or so, that's how it was studied, where we get some bloating and pain benefit. But you can start to get the stool consistency benefit off the bat. So that's a lot of paste stuff, both from OTCs, over the counters, as well as to prescription. Now going out to the tube itself.
Are you taking a prescription medicine for irritable bowel syndrome with constipation or IBS-C? If symptoms like constipation, belly pain, and bloating are still bothering you, it may be time to try something different. Ibsrela tenofovir is a prescription medicine used to treat adults with IBS-C. Ibsrela works differently to relieve the symptoms of IBS-C so you can focus on what's important to you. Ask your doctor if Ibsrela could be right for you. Do not give Ibsrela to children less than 6. You should not give Ibsrela to patients 6 to less than 18 years. It may harm them. The most common side effect is diarrhea, sometimes severe, and your child could get severe dehydration. Stop taking Ibsrela and call your doctor if you develop severe diarrhea. Do not take Ibsrela if you have a bowel blockage. Tell your doctor if you are pregnant or breastfeeding and about the medicines you take. Other common side effects include swelling or a feeling of fullness or pressure in your abdomen, gas or dizziness. Learn more at ibsrela.com/PI or call 1-844-IBSRELA and press option 4. Ready to try something different for your IBS-C symptoms? Ask your doctor about Ibsrela.
Okay, so we're going to talk about things that can squeeze the tube. So we think about them like stimulant laxatives. We'll start at over-the-counter level. So over-the-counter level would be something like your Senna or Senna-Cot. So Senna is actually derived from plants and actually can be very helpful in terms of stimulating the bowels. Sometimes there can be a bit of cramping here, though, so I would start at just like 1 tab and test it out. You can go up to even 2 tabs twice a day. Another fun little trick is for those tea drinkers out there is smooth move tea, actually. So you can steep a tea bag at night, have some of that stimulation happening over the nighttime, so hopefully avoiding some of the cramping, and then ideal world is wake up with a beautiful banana bowel movement. Doesn't
That
always
is
work
definitely
that way.
ideal.
Yeah, that is always the goal. Doesn't necessarily always happen, but I think a reasonable strategy, especially for people looking for that natural option. Another one in the realm of the squeezers is bisacodyl or Dulcolax. I will tell you this is insanely confusing when you're going to the store because there are Docusate, which is the stool softener, the all mush no push, and the Dulcolax, which is actually the brand name that makes the bisacodyl. I think they also do Docusate, so it's insanely confusing. But if you're looking for the true ingredient when you're looking on the back, look for bisacodyl, Bisacodyl. Now that's actually a little bit more effective stimulant laxative, and I do advise it to be start with 5 milligrams, but this can be really effective, especially for our patients without the pain component. It's more the constipation because the stimulation isn't going to bother them as much. I don't use it as much for my IBS-C patients because until we get that turned down in terms of the pain, we may not have as much benefit and more side effect.
That's a good point just to make that, a tenet of IBS is abdominal pain plus these bowel fluctuations. But there are lots of types of constipation too. So you can have constipation without abdominal pain. And to your point, talking about that with your gastroenterologist or primary care physician is really going to help inform many of the treatment suggestions that they make.
You got it. It's all pain, no gain of IBS diagnosis. So it's a little different flavor there and different strategies. And then finally, another somewhat newer kid on the block for a stimulant or a prokinetic, we would say, is prucalopride or motegrity. So that one can stimulate the bowels, albeit in a more gentle fashion. However, it's technically indicated more for chronic idiopathic constipation. So kind of avoiding it with those with pain. So that's really, we're diving into all the plumbing stuff. I don't know how much we want to go into the electricity stuff as far as neuromodulators, but in general for an IBS-C patient, I'm going to focus on the plumbing first, actually, because sometimes getting the plumbing in order, whatever that looks like, paste tube or cap strategies, that may help the pain just secondarily, and we don't even need to go into the electricity realm of the neuromodulators where we're adjusting the nervous system. That's kind of a bird's eye view of the pharmaceutical approaches.
That's awesome. I learned a lot, and I feel like I know the drugs pretty well, but the way you word it is just so simple. That was great. Thank you.
Dr. Brandler, just very briefly, tell us a little bit about what neuromodulators mean and what a patient that's struggling with constipation might get in terms of a prescription.
Totally. As I said, we'll focus a bit more on plumbing first, but this is in the electricity. So neuromodulator means change or modulate the nervous system. And yes, these drugs originally were antidepressants, anti-anxiety, but a lot of times we use them in different ways with these conditions. So for an example, SSRIs can sometimes be used for patients that have predominant anxiety and depression features. And actually, it's because we leverage the side effects to a certain extent. A lot of times diarrhea can be a side effect, which we can totally leverage for a constipated patient, right? So something like a sertraline, for example, Zoloft, we can get by with low dose for that. And that can help calm or settle down the nervous system to a certain extent. Now, with our bigger pain people, I would actually recommend more a SNRI for my constipated pain patients. So that's serotonin and norepinephrine. The one I love the most by far is duloxetine or Cymbalta. It can be incredibly effective and treats so many different things, including the pain for a lot of conditions, depression and anxiety, and has less of a side effect profile, especially constipation. Finally, tricyclics or tricyclic antidepressants actually have the most evidence, and we use them in much lower doses. This is like amitriptyline or nortriptyline I would use in a constipated patient because it doesn't pass the blood-brain barrier as much, but that does have a constipating side effect. So I'd want to get the plumbing down under control first, and then we move into the tricyclics.
Thanks for that.
I think of people, they hear neuromodulation. This is used for depression. My doctor thinks I have depression. What is your elevator speech about that?
I go back to it's not all in your head, but part of it is in your nervous system and in your brain and spinal cord. And the way that we know these work actually, and through the class, I'm able to teach this more, but we are understanding more about these pathways and actually how it can help to control those overactive gut to brain signaling. And the other thing is we can actually get by with lower doses for brain gut conditions than we actually do for full-blown mental health conditions. So that's also why in some ways I'm like, hey, whatever, I'm not even going to put anxiety, depression in your chart because I actually don't even think you're anxious or depressed. I just think your nervous system's all out of whack and let's turn it down. So, that's also sometimes how it can be framed too.
Perfect.
And people aren't going to be usually on these for the rest of their life too. And therefore, having these additional follow-up appointments with you to talk about their, hopefully, improvements can help then inform future treatment. So from that kind of transition, tell us what is the most beneficial information that a patient can prepare to make the most of their time with a neurogastroenterologist or somebody like you?
Yeah, I think first of all is they're probably not going to see a neurogastroenterologist, right? They're going to see a general gastroenterologist, a general GI nurse practitioner or PA that also probably really care, but they're very limited on time. So one of the best advice I can give you is really go in with a good sense of what your goals and expectations are for the appointment. Because inadvertently what often happens is you're suffering, right? You just want to feel better and that's all you want to feel. But that's very hard for the person on the other end of the exam room to address without really understanding what you're looking at, what your goals are, because there's only so much time to cover. I will say actually a shameless plug for a talk I gave a few years ago with the IFFGD or International Foundation for GI Disorders, which you can still find online actually, I gave a talk called Living Your Best IBS Life. And in that, I give you a guide of an IBS snapshot. So a one-page summary of the key points that you can give to your provider that you're seeing. And I will tell you, if you can summarize in a page your basic history of your predominant stool habits, if you're speaking the Bristol stool chart, for example, if you're identifying some of your triggers, if you're doing those types of things, if you can give a one-page summary as opposed to a giant binder or a giga download of your tracker's PDF or whatever, that's going to go so much farther, and that provider is going to feel so much more empowered themselves to empower you with guidance as to next steps. So key goals and expectations for that visit, and then organizing your thoughts and history into a one-page summary, if at all possible, is really, really ideal.
Yeah, I often say, like, of all the symptoms you're experiencing too, kind of like qualify those. Like bloating is the most difficult, or pain is the most difficult, or I'm in the toilet for 14 hours every morning is the most difficult. So the physician can kind of prioritize, right? And you're on the same page.
And quality of life too, like what of these constellation of symptoms most affects your quality of life, and that we can more precision target, because from there a lot of other things will fall in place, because a lot of these aren't quantity of life conditions, these are quality of life conditions. And so if we can really focus on and pinpoint the takeaway from that, then that can really lead to high yield visits.
And Kate and I will talk more about this in part 2, but, just off the top of our head, again, if this is a plumbing issue and you're trying a bunch of different medications over the counter and you're just not sure, and you want some clarity, then having that medical provider conversation is so important. If you are avoiding going to things with your family, if you're at home, your avoidance behaviors, your stress, your anxiety, you are depressed because of your symptoms, that's going to key in our physician colleague to make that consult to a GI mental health provider. Or if you're afraid to eat, you don't know what to eat, you are avoiding meals, again, it's going to trigger that referral to a GI dietitian. So it's really important, again, to be organized and to be open with your physician so that they can help guide where to go next.
And I would add, sometimes you try a treatment, you see the doctor and you say, I feel better, but the doctor doesn't understand necessarily like how better. Like, are you at a 80% of where you want to be, or is it you were 0 and now you're 10? So sometimes making sure you kind of qualify the benefits that you received.
Actually, in my practice now, we're collecting IBS symptom severity scores, so objective scores at the beginning, and then we see that progress. And it's actually so rewarding for myself that we just talked about this yesterday with a patient. She went from like 330 to like 20 or something it was amazing, so rewarding for our team members too. Sometimes we do mental health scores as well to objectively see those changes. So you can work with your provider on how to do that, maybe even do that beforehand for them so that they know where things are at.
Well, this was amazing, and no surprise because you're amazing. I couldn't have wanted a better scenario for this episode. It just covered, from A to Z, and really understanding medications better and the complexity of IBS. And I love the plumbing, electrical sort of system alterations that are associated in very simplistic terms for our listeners. So thanks for your time.
Yeah, thank you guys so much for having me. I mean, I just like blow up Mind Your Gut with patients. I mean, as they're waiting to see me, I'm like, okay, this is something you can read before seeing me. Like it's promoted in the classes. Like it's just, you guys provided such a powerful tool that I've read myself that, as you know, that is very patient accessible and myth busty, which is also incredibly important in a side conversation. So thank you guys so much for what you're doing for patients everywhere.
Well, we look forward to ongoing collaboration with such a rock star in the motility space. And everybody out there listening, please make sure that you subscribe, like, and follow the Gut Health Podcast. Your support means the world to us, our friends.
Thanks, everyone.
Thank you for joining us as we grow this gut health community. We hope you enjoyed this episode, and don't forget to subscribe, rate, and leave us a comment. You can also follow us on social media at the Gut Health Podcast, where we'd love for you to share your thoughts, questions, and experiences. Thanks for tuning in, friends. Thank you for joining us as we grow this gut health community. We hope you enjoyed this episode, and don't forget to subscribe, rate, and leave us a comment. You can follow us on social media at the Gut Health Podcast, where we'd love for you to share your thoughts, questions, and experiences. Thanks for tuning in, friends.